Medicine is inherently a moral enterprise. Leon Kass, a physician and philosopher at the University of Chicago, says this repeatedly. And what he means by this is that the practice of medicine involves making decisions. Decisions that may be good or bad, right or wrong. Well, if that's true, and if that's been going on since Hippocrates or before, why is bioethics a new profession? This subheadline from the New York Times said that the term entered the language only in 1971. It was probably in the 1960s that theologians first and philosophers subsequently began to ask questions of physicians. Physicians can address the can we questions. Those are medical questions. But the ethics questions, the should we questions, are new in the practice of medicine, and from that has developed the whole discipline of medical ethics. I heard this maxim 25 years ago at a terminal care conference in Montreal, said by a urologist. I have no idea where it came from, but I say it at least 10 times a week to anyone who will listen. The ability to act does not justify the action. Just because we can do something doesn't mean we should do something. Just because we know how to dialyze patients doesn't mean that every older patient with dementia and stroke and no longer able to interact with their environment when they go into renal failure doesn't mean that we have to dialyze those patients. So we're forced to make some decisions. Well, why are we making more decisions? Why is bioethics come along beside the practice of medicine? Well, there are lots of reasons, and we could spend a long time on this. I'm just going to very briefly mention that, of course, technology is one of the primary reasons. There are so many more things that we can do that we have to stop and scratch our heads and say, should we be doing that? There's the changing doctor-patient relationship. From the paternalistic physician who said, this is what should be done, this is what will be done, this is what you will do, to the pendulum swung all the way over to the autonomous patient who said, this is what I want. And I think there's some correcting of that pendulum now towards the middle for shared decision-making. But not only has that one-on-one relationship changed, but the practice of medicine has changed. It's much more common now to have team care of patients, more than one physician involved, and family members and so on. So and the changing finance scheme in medicine and so on, which leads, of course, to cost containment. Everybody is looking over everybody's shoulder to see who's spending what on what, and is it being cost effective. So all these things combine together, and other reasons as well, to cause us to ask the should we questions. I'd like to make a difference, perhaps a subtle difference, between medical ethics and clinical ethics. Medical ethics really looks at issues, and clinical ethics looks at patients. And I say that without apology or defense, because for the time that I've been here at this conference, I've been once again impressed with how little I know about philosophy and theology. But I am a clinical ethicist. I'm a bedside clinician. I'm a practicing physician first, and I do ethics consultations. I get called by physicians to go to the bedside and help make guide decisions about what should be done for a particular patient. That's what I spend most of my time doing. Clinical ethics is the identification, analysis, and resolution of moral problems that arise in the care of a particular patient. And there are at least two different perspectives in medicine. And I think we've seen both of these perspectives demonstrated here this weekend so far. I came away from home without my laser printer, or my laser pointer, and I feel a little bit lost. If I point my ballpoint pen, do you mind? It'll help a bit. Any of you compulsive paternalistic physicians have a laser pointer in your pocket? No. I wouldn't be surprised if there were three here. Anyway, there are at least a couple perspectives in medicine. On the left is the medical practice perspective, where I spend most of my time. We look at individuals who are identified lives. They have names and faces with personal concerns, and we look at them case by case. We're very concerned about patient autonomy. We're very concerned about compassion, beneficence, doing what's best for patients, and we are patient advocates. But there's another perspective, which we mustn't neglect, the health policy perspective, which looks at society, which looks at statistical lives, looks at effectiveness and general principles, very concerned about justice issues and protector of society. Now, we are citizens as well as physicians, and sometimes we are confused about which hat we wear at any particular point in time. And with the changes in healthcare financing, we're being increasingly asked to wear more hats all at the same time. But we have to be aware of what role we're playing at what point in time. But I am primarily a clinical ethicist. Now, the goals of clinical ethics, there are at least two subsets of goals. There's process, the method of reaching decisions, and there is outcome or substance, what decisions are reached. And I think both are important. Part of the process portion of my ethics consultation is to facilitate ethical reflection, to look at the ethics questions, to clarify some of the concepts of futility and autonomy and surrogate decision-making and so on, to describe precedents, legal precedents and moral precedents, to uncover new facts, to encourage communication, to give emotional support. Many of these decisions and processes are very tense, very difficult, and oftentimes, having been through it with other patients and families and physicians, it's easier to help people through the process again. Help resolve misunderstanding. Many of my consultations are not really ethics consults. They're communication consults. The physician is talking with the chart, and the nurse is talking with the patient, and the patient is talking with the social worker, but nobody's talking to each other. Probably the best tool that I have in my armamentarium is a management conference, where I get all the people together in the same room at the same time to listen to each other, to hear each other. Helping resolve conflict. Very often, the situation is the physicians want to do this, the patient doesn't want that done. Or, more commonly, the patient or family wants something done and the physician is reluctant to do it. You have a difference of opinion, and how are you going to resolve that conflict? I took a one-week course in mediation techniques, and it's been very, very helpful. So process is an important part of ethics consultation. But so is outcome, so is substance. We are trying to reach decisions which are professionally sound, ethically justifiable, legally defensible, culturally sensitive, and financially feasible. Is that too much to ask? That's my job description. And because some people have been particularly concerned that clinical ethics is too process-oriented, just the day before I left, I thought I would pull together some of the questions that have been asked in ethics consultations. And I don't have them on slide, but I have them on overhead here. You can't read them, but I will read them to you. Just something for you to look at so you don't have to look at me. Process or substance? Just ask yourself as I read. When I started ethics, the most difficult part of doing an ethics consultation is identifying the question. It's not the answer, it's the question. What is the question that's being asked here? Why are people uncomfortable? Why is there conflict? So at the very top of my consultation is the question, once it's been formulated. And I've just lifted out the last 10 questions from the last 10 consults, and I'll read them to you. What measures are appropriate for this infant who did not die as anticipated? Stopped life support, baby didn't die. Now what do we do? That's substance, it's not process. May we stop this patient's ventilator on the basis of her living will? That's process. Well, some substance. Must we intubate this man in the persistent vegetative state because his family says, do everything? What are the ethically permissible treatment options for this pregnant woman with severe thyroid problems? One, just help in dealing with uncertainty. How do we cope? Process. What are the ethically permissible management options for this woman with a severely abnormal fetus? Substance. Is it ethically permissible to continue to prescribe narcotics for this patient who admits to their misuse? Substance and process. May we accept this adolescent Jehovah's Witness's refusal of blood transfusion? 13 and a half years old. Baptized 3 months ago. Said she didn't want to have blood, she would rather die. Can we accept that? Is it permissible to treat this woman against her will? Can we put her in restraints and start an IV that she doesn't want? Is it legally permissible to withdraw life support from this patient? So there's both substance and process involved in ethical clinical decision-making. Now, the principles of medical decision-making, how do we go about it? As you just noticed, most of the consultation requests are about specific options. Should we do this? May we do this? Must we do this? But before we can even approach that question, we have to remind ourselves of at least two other things. There's shared decision-making between patient and physician, family and physician, entire healthcare team, and so on. It rarely is a unilateral decision about what should be done. And the second thing is we have to decide where we're going. We have to establish our goals. Because often we're wrestling with whether or not to do a ventilator, and we haven't stopped to think, is our goal prolongation of life? Is our goal comfort care? Is our goal returning the patient home, and so on? Now, what goals are possible? That's really in the medical domain. But what goals are desired? Not desirable, but what goals are desired? That's in the patient-family domain. And we have to bring all these things together. You can see where I learned my philosophy from the comic page. Now, this is where it gets tricky. Can't read all the signs, but one of them is pointed towards moral ambiguity. That's why I thought that fit here. Good ethics begins with good facts. A truism that I also say repeatedly, we have to know the facts before we can address the values. Now, this is a dangerous slide. I have been known to spend as long as an hour and a half on this one slide. And how long do I, let's see, we finish at 9:30. Okay, 5 minutes max on this one slide. And this is the method that I use in analyzing a problem. And this is adapted from a book that I would highly recommend. It was on the book table yesterday, Clinical Ethics by Johnson, Siegler, and Winslade. It's a very good, practical, down-to-earth, how do we address DNR issues and limitation of treatment and so on. And the idea is that when we're confronted with an ethical dilemma, there are at least 4 sets of factors that we need to think about. There are the medical indications in the upper left-hand quadrant, the patient preferences in the right upper quadrant, quality of life in the left lower, and contextual features in the right lower. And I set them up in this quadratic fashion for a very specific reason. Because 90, 95, maybe more % of the time, we can resolve the issue staying above the line. We can look at the medical indications and the patient preferences and come to a conclusion. But sometimes we have such a poor prognosis and no idea what the patient wants, but we still have to make a decision. That's when we drop below the line and look at the secondary issues of quality of life and context. Let me flesh this out just a little bit. And I have a patient story attached to every single word on that slide. And I promise not, well, there's one I've got to tell. But medical indications. We like to think that the left upper quadrant is facts, and mostly it's facts. The diagnosis, and not only the diagnosis, but how certain are we of the diagnosis? Because oftentimes the dilemma is because of uncertainty. Will one more test give us an answer? Is there any way to be certain? What's the nature of the disease? Is it an acute reversible process? Is it a chronic progressive illness? Is it a fatal illness? What's the condition of the patient? What was their condition at baseline? What's their condition now? And then prognosis. Now, I said this was facts, and you and I know that prognosis is not a fact. Prognosis is a guess, an educated guess perhaps, but there's a little bit of crystal ball gazing that goes on here. And the physician's prognosis often depends upon his or her training, experience, what journals they read. I mean, if the last 10 patients that I've put on a ventilator, 6 of them have done well, I'm going to be more inclined to use a ventilator this time than as if 8 of them have done poorly. So personal experience enters into prognosis. Then treatment options. What can be done? This is the can-do side. On the right upper quadrant is patient preferences. And when the patient has decision-making capacity and you talk with them, you explain these things in the left upper quadrant, and you help them determine what are their values, what are their goals, and what are their specific treatment desires. And part of our job as clinicians and as a clinical ethicist is to be sure that the patient has been adequately informed and that they are not being coerced by family or physician or finances or other factors. So the upper half of that box is for the patient with decision-making capacity. But most often when I'm asked to do a consult, it's because the patient cannot talk to us, either because they're an infant or they've had a stroke or a head injury and they can't tell us about their values. Then we look for other means of recreating or creating a substituted judgment, trying to make the decision that the patient would make. And I understand the difficulty that this is now not the same person who you talked with before, as we heard about yesterday, but still we have to have some mechanism of trying to reconstruct things. So we look to advance directives sometimes. How many people in this room have a written advance directive, a living will or a durable power of attorney for health care? Just a little bit worse than the national average, okay. Has the patient ever said in the past what he or she would want? Have they ever said, I would never want to be hooked up to machines long term. I don't want to be like Nancy Cruzan. I don't want to be like Aunt Tilly, or I do want to be like such and such, or whatever. Have they ever made decisions for themselves or for someone else, which might give you some idea of their values? But as I mentioned, sometimes we've got a poor prognosis, no idea what the patient wants. Then we drop down and look at quality of life. Now, the words quality of life give many people shivers, thinking that it's either sanctity of life or quality of life. Well, I'm here to tell you, quality of life is not a dirty word. Everybody has a quality of life. My quality of life is pretty decent this week. Last week I had a backache. It wasn't quite so good. Quality of life varies from day to day. But the most important thing is that quality of life is very personal and very subjective. And it is multidimensional. And physicians and nurses and people in medical practice are very poor judges of patients' quality of life. There have been 5 or 6 studies now that have shown that if you ask patients about their quality of life and you rate them on a quality of life scale, and there are 100 different scales you can use, but you ask them and you get a number, and then you ask the caregivers about the patient's quality of life, whether it's home caregivers, family caregivers, or professional caregivers. Always, 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 the patients say their quality of life is higher than their caregivers say. Patients will put up with a lot. I learned that this is the one story, maybe this is the one story I'm going to tell, but on this side. I learned a lot about quality of life from a young man, 33 years old, who until age 22 was perfectly healthy. Professional musician, loved to play football, very active and so on. And then he got sick and overnight was transformed into a ventilator-dependent quadriplegic. He got a viral infection of his spinal cord up in the neck, and he was unable to breathe on his own, unable to move anything below his chin. For 11 years he had been like that. He'd gone through rehab, he'd been cared for at home by his family, and had done quite well for 9 years, but in the 2 years before I was asked to do a consult on him, he had had repeated respiratory infections. One pneumonia after another, each one requiring a little longer hospitalization, each one requiring a little stronger antibiotics, each one with more resistant bugs, and each one leaving him with more residual secretions. And he had talked with his pulmonary specialist, and he recognized that he was dying a pulmonary death, slowly. He was in the hospital again with another infection, under treatment, and was actually getting better. And he said to the young resident taking care of him, you know, I think it's time to stop the ventilator so that I can die. And she came to me and said, he wants us to help him commit suicide, and we can't do that, can we? And, I mean, that's a whole discussion that we could have for some time. I'm not going to focus on that. What I want to tell you is what I learned from this young man. When I went to talk to him, I said to myself, I talked with his home care nurse and his hospital nurse and his brother and his mother and his best friend, and I got a picture of him, and then I went to talk with him spent a long time with him. And I said to myself, this poor bugger, 11 years lying on his back, hooked up to a machine. What a poor quality of life, I says to myself. Didn't say that to him, obviously. What I said was, tell me, what's it been like for 11 years? And the first words out of his mouth were, it's not been so bad being a quad. I said, tell me more. He said, well, my family loves me, and they take care of me. I have friends. I had friends before I got sick. They're still my friends. They come, and I have a portable ventilator and a van. They take me out in the van, go out to the shooting range. I watch them shoot targets. I watch them square dance. I have a voice-activated computer. I can turn on my CD player. I can make phone calls. It's not been so bad. I was looking at his physical dimension and said, poor quality of life. He was telling me that his psychological, social, cognitive, spiritual dimensions were okay. Quality of life is a very personal and subjective item. Must move along. Context. The last area, almost always the first area to be asked about in consult. You know, well, what's going to be the effect on this patient's family? Or what's the law say about this? Or what about finances? And we must think about those things, but we must go through these other things first. The cultural issues. Finances, institutional policies, and so on. We must move on. Levels of moral agreement and disagreement. What do we do when we don't agree? Well, sometimes we agree and we go along. Sometimes we disagree and we go along. Sometimes we disagree and we opt out. I'm sorry, I cannot be involved in that. Sometimes we disagree and we actively oppose a person's decision because we feel it is morally wrong. When I was younger and smarter, I used to think that things were pretty black and white. Things in medicine, things in life in general. But the older I've gotten and the more gray hair I've gotten, the more gray I see between that black and white. And some of that gray is because some things are ethically neutral. They are neither right nor wrong. But some of the gray is because of confusion. Some of the gray is because of ignorance. And part of my job as a clinical ethicist is to help families and physicians and healthcare team cope with the ethically neutral and the uncertainty. And part of it is to help them sort out the confusion and the ignorance and move those areas into black or white when that's appropriate. A lot of people think that ethics is a soft science, but I just want to let you know that there's some hard research going on. These are two Loma Linda ethics professors who are doing some research. Yes, I know that, Sydney, everybody knows that. Well, look, 4 wrongs squared minus 2 wrongs to the 4th power divided by this formula do make a right. Now, the method of case analysis, which I should say, by the way, is not the only way to analyze cases. There are lots of ways. David Thomas has an ethics workup that he does that's quite workable. The one that I showed you is just the one that I happen to use and be comfortable with. But it's a very casuistic approach. And I think physicians fall into casuistry very easily because physicians look at cases. What are we going to do? This case is a little bit different from this one, and how do we decide, and so on. And when I first became acquainted with casuistry, I thought it was situation ethics and relativism, and it made me nervous. But the more I've learned about it, the more comfortable I feel. The dictionary says casuistry is that part of ethics which resolves cases of conscience, applying the general rules of religion and morality to particular instances in which circumstances alter cases or in which there appears to be a conflict of duties. It's a way of working through things and deciding which theological, ethical, medical principles apply in this case and why there's prioritization in this case differently from another case. That works. It's practical. However, it's not enough. Ed Pellegrino, in a beautiful essay in JAMA last year, I think the title of the essay was Compassion is Not Enough, said casuistry is a useful method of case analysis, rooted in legal procedure, but it's a dubious way to establish a moral norm. The problem with relying solely on the casuistic method of paradigm cases is that there must be something beyond the case by which to judge the case. And I think this is particularly pertinent for Christian physicians. And I'm really nervous showing these next few slides with all you philosophers and theologians out there, so I'm going to whip right through them and hope that there aren't too many questions. But I just want to point out that there are different levels of thinking in ethics. I spend most of my time down at the bottom here. Ethical decisions. What are we going to do for this particular patient? And we help decide that by looking at the ethical rules. And the ethical rules can change. The ethical rules include state laws and professional oaths and so on. In the Oath of Hippocrates, which I think very highly of, the physicians swear not to operate for kidney stones. Not because there's anything inherently wrong with operating for kidney stones, but back in those days, if you left a kidney stone alone, there was a possibility it might pass. And if you operated, the patient was almost surely going to die. So there was reason behind it. Anyway, the rules can change. Brain death, concept of brain death is a new rule. Where do we get the rules? Well, the rules come from ethical principles, and there are fewer than one might think. And those principles are based on the person's ethical system or method of moral reasoning, and that is determined by their worldview. Now, the reason that I'm going in this direction is I'd like to point out that there is a difference. I mean, you all know this, but there is a major difference between the way that Christians or theologically oriented people look at these things than the secularist does. And I'd like to try to flesh out this outline with the two different perspectives. On the left is the secular anthropocentric worldview, which says that man is autonomous, that reason, human reason, is the way to go, and is looking for universal principles. The Christian, the person coming from a God-centered universe, says that God is sovereign, and that there is revelation from God on how we should act, and we look to biblical principles. This is the slide that really scares me. So, the methods of moral reasoning. The secularist looks at teleological methods or deontological methods, or may use casuistry. And the Christian, too, primarily looks at deontological methods, biblical, in quite a variety of different schools. Legalism, antinomianism, situationism, and casuistry as well. Then the principles. This is the one that I've spent a little more time on and want to continue to work on. I would appreciate your feedback on it. On the left side, the secularist has what's been called the Georgetown mantra of beneficence, non-maleficence, autonomy, and justice. And the Christian subscribes to most of those as well. But we work with compassion and the sanctity of life principle. We're concerned about truth-telling and chastity. And one that we don't like to talk about, don't like to think about, there may be some value in suffering. Now, you hardly ever find a secularist that will admit that or subscribe to that. And many Christians are very uncomfortable accepting that. But I think that there is teaching about that in Scripture. In relation to autonomy, which is so prevalent and has been so dominant in the secular ethics field for so many years, Christians too believe in free will and dominion over oneself and over the earth and so on. But the next step is going beyond to stewardship of our resources and ourselves under a sovereign God. It's really a different worldview than just the autonomous individual. We too believe in justice. Justice, as you know, is getting what you deserve. But we also believe in mercy. That's not getting what you deserve. And we believe in grace. That's getting what we don't deserve. And all this is couched in a context of eternal hope. So I think there is a difference in the way we look at these things. The Bible speaks to ethical principles when Micah says, God has shown you, O man, what is good. That's ethics, right? Looking for what is good. And what does the Lord require of you but to do justice? There's one. And to love mercy. There's two. And to walk autonomously. Oh no, that's not what it says. And to walk humbly with thy God. The rules, I must move on. We have, in the secular worldview, we have state laws, case law, codes of ethics, institutional policies, aphorisms, and so on. And the Christian, too, subscribes and respects these as well, but has, in addition, the Old Testament law, the life of Jesus, the Sermon on the Mount, epistles, and so on. And making specific decisions. The secularist talks with the patient first, includes the family. When there is conflict, may involve the ethics committee, and when there's unresolvable conflict, may go to court. And the Christian has these same options. We talk with the family, the patient, include the family. But we also have a moral community. And I think we sometimes don't rely sufficiently on the moral community and involve the individual's pastor and church community. And we have the Holy Spirit, and I put that up with a little bit of reservation because I don't want people to think I'm being flip about this, but I really do think that we have a spirit that we can look to for guidance in specific cases. So what we are left with as Christians in the medical ethics realm is, I was going to say a juggling act, and that too sounds flip, but we are really trying to balance the sovereignty of God, the stewardship of the physician, and the autonomy of the patient. All true, real entities with which we cope on a day-to-day basis. We've talked a fair amount about technology. Technology has introduced problems, but technology is not the problem. The problem is uncertainty. And we deal with this all the time. And we don't have black and white ways to deal with uncertainty. We are right in the middle of the gray. Dealing with uncertainty, we can use human reason, we can use tradition, medical tradition, and so on, or we can also use meditation and revelation to try to help us deal with uncertainty. Matilke has said, do we not have to accept the fact that under the shadow of forgiveness, different decisions are possible and different liberties and loyalties exist? That gives me a sense of reassurance as I deal with patients and uncertainties and some of the gray areas in medicine. Thank you.
Can I just ask the old chestnut about the family doctor who sees the pregnant patient who wants an abortion, and after trying to listen to their concerns and trying to suggest that maybe there is a larger context in which to think about these things, the feeling is that I still want an abortion. I've always felt that it's a violation of my integrity, in a sense, to facilitate their finding one. And yet, on occasion, I have, thinking that it was just my own sense of wanting to try to maintain a kind of purity that really didn't exist, and I would, in fact, give them some information.
I think that's a very practical question, and what you're really asking about is moral culpability, and I've wrestled with that in my own practice. And when I was in practice in Vermont, I was in that situation many times, and my own personal scruple was that I would not refer a patient to a specific physician to get a specific abortion. I felt that in our community it was well enough known where abortions were available, that if a patient chose that after our discussion, I mean, I couldn't and I wouldn't stand in her way, I wouldn't call her names or tell her she was an evil person or anything of the sort, but neither would I facilitate her getting into the system to get it. I would tell her, I understand that you've come to that decision, and I will see you back afterwards and help you and so on. And there are services available in the community, and I wouldn't give her a specific name. And I never had anybody upset with that. And I've known Christian physicians who were more comfortable going the one step further and say, I know that Dr. So-and-so does good quality work, safe, and so on. And I think that's a matter of conscience.
Thank you for an excellent presentation, very clear and cogent. Just had a question about the middle gray area of neutrality to which you alluded. Your religious convictions are obvious through your presentation. I was wondering if you feel that the broad and seemingly increasing area of neutrality is due to a lack of covenantal concept in that clinical, that medical relationship. Given the tendency in society, at least legally, to establish precedents on difficult cases as opposed to allowing the principle to guide the difficult cases, how do your convictions bear on this huge, seemingly growing gray area of neutrality? Is it indeed neutral?
Excellent question, and I am a casuist. I really look at things case by case, and there are some situations that I really think that I can't be dogmatic or definitive in saying this is right and this is wrong. And there are some treatment situations, I mean, we can take it out of the life and death scenario, but there are many treatment situations where there are three perfectly acceptable medical options for a particular treatment. Coronary artery disease, you can have intensive medical treatment, you can have a bypass surgery, or you can have an angioplasty, and there are pros and cons for all of them. And I talk with patients about the pros and cons, and I think that's morally neutral, and they can make a choice. And then as we get out towards the areas of life and death decisions, I think the gray begins to take on more shades of black or white. And I'm not sure where that line starts or stops. But I am a little bit reluctant to see too much in the area of public policy trying to define the black and white, because I'm afraid the public and I are not always in agreement about what is black and white. And tough cases make bad law, or something. You've all heard that. And I think if we look only at the really difficult cases and try to formulate a policy from those, we're going to exclude a lot of others that really truly are gray.
I think undergirding much of what you said here is the dilemma of trying to decipher when are we prolonging life and when are we prolonging death. And I'm reminded of a cartoon I saw some years ago where a person was rushing up to the pearly gates and met St. Peter. And he says, "I'm sorry I'm late. They had me on life support for 3 months."
This is going to turn into, can you top this? But R.C. Sproul was talking to the CMDS a year ago, and he said he went to his doctor for a physical, and his doctor said that he was looking for risk factors for premature death. And R.C. Sproul says, "But I'm a Presbyterian. There is no premature death."
Dr. Orr, you said that, well, you gave the indication that sometimes there is a dilemma in ethical decision-making. And I wonder, because you're thinking about the patient's quality of life, and I wonder how much of that is due to the medical community mistakenly thinking that a patient's quality of life is purely dependent upon the patient's medical condition. I think someone like Joni Eareckson Tada, or my husband's aunt, who's 92 and on dialysis, but was a church organist for 70 years and is a committed Christian. I think there are people who would say, no, my quality of life is certainly not solely dependent on my medical condition, as did the young man in your example.
I think that's an excellent point, and I hope that that came through in my discussion of quality of life, that it's really not my decision as a clinician, it's the patient's decision about the quality of life and how they cope with that quality of life. I mean, some people will say, my life is miserable, but that's the way things are, and I'm going to look to God to see what He wants from me in this situation and so on. So I think not only the assessment of the quality, but what you do about it is a very personal and spiritual question.